So I'm very happy to be joined today by Dr Hugh Seward and Peter Kirwan. Doctor, give us, the audience, a bit of a background on what your role is and where you're working at the moment.
I work for both Worksafe Victoria and TAC in Victoria. Fancy titles, I think, probably overstate it, but I'm the Medical and Recovery Director at Worksafe, and I head up the medical side of the clinical panel at the TAC. But my background is as a sport and exercise physician and a GP of 40 years.
Wow. You don't look a day over 45.
Thank you, Greg.
And Peter?
So I'm a technical rescue instructor with Fire and Rescue New South Wales, and I also sit as the co-chair on the State Insurance Regulatory Authority of New South Wales Lift Experience Reference Group.
And you're both just off stage after your presentation at this year's Personal Injury and Disability Management National Summit for 2023. Well done. It was an excellent presentation. I'm going to have to read this because it's quite a long title, but your topic was a person-centred approach in action, putting clients at the centre of case management to deliver the best possible outcome for injured workers. Now, Hugh and Peter, I don't mind who. We're podcasting, so we can talk right over the top of each other. Such is the benefit of these things. What in the world is a person-centred approach?
Well, from my position as the lived experience person on the panel, it's all about me.
Mm-hmm.
Not necessarily.
Are you high needs?
I could be. It's not necessarily about me getting everything that I ask for from the system, but certainly the system taking into consideration what my needs are at every step along my recovery journey.
And Hugh, do you think the system does?
Well, I'll speak from the GP's point of view. General practitioners provide person-centred care. That is the way they do their business. That's the way they look after people with empathy, and there's an enormous degree of trust that their patients place in them. And the challenge they have with someone with a compensable injury is that the system is really complex, and they have to their way through that. And they also have to understand that it's really important, even more important than their average patients, to promote high value care and, as Peter said, not necessarily give patients everything they want, but direct them away from low value care. So they might not get an MRI for their low back pain. The difficulty for the GP is that takes more time to explain why they're not doing the imaging than to write out the form. And we know that the MRI produces all sorts of odd results which take people down treatment rabbit holes that they don't want to go down, and promotes an impediment to good recovery.
And have you found with the corporatisation of the health system, have you found person-centred care even more difficult when, clinics with 15-minute allocations are providing GPs with greater challenges?
Well, I was in general practice for a long time, and I've gone through that whole change. And I think because of the decreasing numbers of GPs, that corporatisation, as you say, some of the priorities within the medical model have changed, and it does detract from that opportunity to have a really empathetic approach, because you've got other pressures on you, and that does detract from that effort to provide honest person-centred care.
And speaking from lived experience, Peter, and you would be very familiar that a lot of compensation issues are the overarching element is legislative. In your opinion, do you think the legislation has person-centred as its heart?
I think the legislation does, but it's about the application. I mean, ultimately legislation should be neutral. It shouldn't be favouring any one particular group. It should be for the benefit of the broader community. So, but legislation can be interpreted. And I think there's other pressures on the system, including profits and all those other external forces that come in, shareholder dividends, superannuation schemes, buying shares in insurance companies. So I don't think the legislation is necessarily the problem, although it's probably quite complex, well beyond my scope to interpret it. But I think it's just part of a broader system that you know, the 1%ers are going to make a difference long term if we keep adding them up.
So we've got an overarching legislative arrangement, broadly speaking, trying to treat people equally. We apply a person-centred approach. Now, I'm from the Victorian scheme. Over 60,000 persons pass through the workers' compensation system every year. That's a lot of centres.
But person-centred approach isn't about, as we said before, about giving everyone everything they want. It's about understanding what people want at that particular point in time, and it's about the case manager and the return to work coordinators and those people understanding where someone is on their journey. And it's about a relationship that's developed amongst all the people in that process. So the insurance company, the return to work coordinator, the GP, potentially any other specialists involved, whether it be a psych claim or a musculoskeletal claim, and the injured worker. You know, there were days with my back claim where I struggled to do the washing up. But and at that time, I probably could have been supported with someone being able to assist me with household chores. But that wasn't forever. And, you know, it's about person-centred. It's about understanding what the person needs. And again, going back to what you were saying about having high-value healthcare, not necessarily just about giving the people the lollipop because they asked for the lollipop.
Yes, yeah.
There are all sorts of distortions in our system, and those. But at the foundation, every provider, no matter what their discipline, wants their patient, wants that person to recover. They all want the best outcome, and we should never question that. But the distortions that our whole medical system is based on interventions, and people, surgeons and pain physicians, and even the GP gets funded per encounter or per procedure, which distorts it. We've got secondary gain when people have an injury, and instead of just having to get better to get back to life, someone's going to pay. All of these things have been developed with really good intent, but they do distort the outcome as we see it within our system, within our schemes.
Now, looking forward, Hugh, so it's about the future of work, and obviously in your context about the future of recovery and the future of medical practice and the future of support systems. Looking into the future, what's your view?
I think we need... somehow we've got to cut through some of those barriers. We probably need to modify some of those distorting factors and enable people to get on with the job of an empathetic care that's appropriate. So education, knowledge, support and upskilling from the case manager to the GP practice nurse, to the GP, to the specialist, to the physio, to all of those people involved have to be able to get on with their job in the best way possible with our support, not with our blockades or impediments that we place. It's so easy for me to roll those that language off, but it's tough. It really is tough.
Yeah. And Peter, the future?
I'd like to see a system where if an employer changes insurance companies, especially one of those smaller insurers and smaller employers, what happens to that injured worker through that transition, or when the claim is closed, as it is mine for my back injury, even though it's permanent, my claim is closed. But if my organisation gets a new insurer, I have to go through the process again. It's even though it is a permanent injury, if I aggravated, I have to open a new claim and have to go through the process again, I have to enter the system again, rather than the system acknowledging that it is a permanent injury. Yes, I have been deemed returned to work. I have a permanent full-time position, still with my employer. But it'd be a new claim because my last one was closed. And there's efficiencies that could be made there as well.
But also for you personally, to relive that whole experience to somebody new cannot be fun.
I am getting quite used to it because I do a lot of talking about it to try and raise awareness and reduce stigma, especially for my psychological injury claim. But I'm probably lucky compared to others that are out there that have to go through it again, that maybe aren't as strong or don't have such a good support network around them. So,
or they don't have English as their first language.
Yes,
and,
exactly. Yes,
they don't have the cultural supports around them,
or the literacy, even just the literacy, even. So there are issues that go along with it, but I think long term, if and I don't know whether this is the solution, but the patient's history has to stay with the employer or the insurer or whatever. And if you leave a job, what happens then? And because entering the system is hard enough, because it does, whether it by design or not, it still feels some degree, or did for me, adversarial. So, I had my psychological injury claim in, and then I had to go and see the insurer's nominated practitioner and relive it again. And that was anxiety inducing. And,
exactly.
So I don't want to have to do that again. And potentially I probably could have made claims on my back injury again because of ongoing pain. But I choose not to because the system is problematic for me.
Well, congratulations on an excellent presentation today. It was really worthwhile and really great to listen to the whole panel, including you, and thank you for being part of our podcast today.
Thanks, Craig.
And enjoy tonight.
Thank you.
Yes, thank you.
Thank you so much.